Next up is Dr. Brian Reemsten. He is the director of UCLA's Congenital Surgical Program, a good friend, fantastic surgeon, and he's going to talk to us about surgical considerations in single ventricle patients.
Thanks. I need a second to get my computer out here. So the name is Surgical Considerations in the Single Ventricle Patient. And after the last two talks, it's kind of in reverse, but I thought it might be better suited as creating the monster that was just discussed by the two people before me, or better yet, probably job security. So the single ventricle, I'm kind of going to talk about how all these patients come to be, and these Fontan patients, and the patients that are probably the most difficult to take care of and take this multidisciplinary team. So first of all, definition of single ventricle is characterized as one suitable pumping chamber. There's a few diagnoses that Dr. Lin talked about. That the two most common are tricuspid atresia and hypoplastic left heart. This is a pathway, and we talk to the parents about when these children are born, what the pathway is going to be. It's usually 3 operations, but there's really four things that we talk about when we discuss this with them. The operations, and then there's an interstage area, which is very significant. I'll talk about the results, near, meaning the perioperative mortality, morbidity, and then the far, how these patients do once they're out, and some of that is actually something we're learning and history is being written. So we'll talk about the optimization of these patients, which is so crucially important to their survival, not only at the time of the operation, but beyond. So step 1 is the initial palliation. If you had tricuspid atresia, essentially it's just usually a form of pulmonary blood flow, either restriction or adding a shunt. However, in the Norwood operation, it's a huge high-risk operation. Still remains the most high-risk operation we do. And it's generally within the first week of life. There is, when we do the Norwood operation, utilization of a bypass circuit and circulatory arrest, and obviously it's a difficult operation. And then there's some sort of pulmonary blood flow, and we'll talk about the implications of what that is. So I'm going to talk mostly about hypoplastic left heart syndrome, mostly because it's more well publicized and more well known because of a few things. Number one, it still is one of the more common defects we see, and still remains the biggest reason for cardiac death in the first year of life. It's the ultimate team concept, and it's really a benchmark. And we say a very common statement is that you can judge your team based on your Norwood results, and you can base your surgeon based on your switch results. And our switch results are very good. And this is actually the best example of this is in the U.S. News and World Report, is that there's 20 questions on your surgical results, and 5 of them have the diagnosis of hypoplastic left heart in them. And there's no other diagnosis from the whole thing. So it's amazing, these 5 questions, it really shows how good your team is, because it's a really multidisciplinary team. And it's the 49% is what I tell patients, parents, when we're doing the operations, that I can do a perfect operation, and I've done about 49%, so we have a good start. But the other 51% is the post-op care. And honestly, I don't even mention that the pre-op care is almost equally as important as the post-op care. Again, history is being written, and we're going to see where these patients are. We started in '85, and so most of the patients that lived are just in their 30s. So hypoplastic, the diagnosis, obviously Dr. Sklansky talked about this very eloquently, and obviously in utero diagnosis is important for many reasons. So the preoperative therapy, usually I said we have the operation, the baby has the operation about 4 to 7 days, and it's a balance of their pulmonary and systemic flow. And so we utilize the airway breathing and circulation, in other words, the ventilator and vasoactive drugs to create the balance that we need so they don't over-circulate. This is a cartoon of the heart showing normal anatomy, right atrium, right ventricle. This is the left atrium, left ventricle, then pumping out to the aorta. Again, right ventricle pumping out to the left lung, right lung. Hypoplastic left heart here, normal right atrium, right ventricle, again pumping out to the pulmonary artery, left PA, right PA. You see a very diminutive. LA is usually normal or small. Left ventricle is maybe present or like a peach pit. He has aortic atresia here, so there's no antegrade flow. So we're dependent on the ductus arteriosus here to give us retrograde flow down the arch. And so this is the balance I'm talking about, because when the blood gets to here, it can go out to the PAs or go out to the systemic circulation. And you rely on your ventilation and vasoactive drugs to create this balance. I'm going to go through a few videos. I'm going to go through them very quickly because we only have 15 minutes, but go through what we actually do in the operating room. Again, this is a cartoon. Right atrium, right ventricle's down here. This is a pulmonary artery that's been divided already and overstone, and this is the fillate open aortic arch and the head vessels. And I'll show you some videos again real quick, actually. So head's down here, feet are down here. I'm on this side. This is the aorta that's been filleted open, and I'll be dissecting out the descending aorta very vigorously. You can see there's this kind of tissue that's very corrugated, and that's the ductal tissue that we have to remove. So this is filleting open the descending aorta. You see this is the whole ascending aorta and arch that's been opened up. This is the patch we use. It's a decellularized patch of pulmonary homograft right here, and then we use this to augment this entire area. We used to use one that wasn't decellularized, and we found that these patients had to go to transplant. They were very immunized or had antibodies and weren't very good transplant candidates. This is the, actually, I'm going to move this along a little bit. This is now the ductus that's been divided, and we're dividing the pulmonary artery at its bifurcation. This is the proximal pulmonary artery that's going to be anastomosed to our filleted open ascending aorta, and then the patch will be used to augment the rest of the entire thing. So I'm just going to skip ahead. So this is our finished product again. Again, the SVC, right atrium. This is the pulmonary artery that had been divided, the filleted open ascending aorta that's been patch angioplasty, the entire thing. And now both valves, if there is antegrade flow in the aortic valve, are responsible for systemic flow. And now we have to do the pulmonary blood flow. So we've disconnected the pulmonary arteries from the pulmonary artery, and we have to establish pulmonary blood flow. Originally described by Norwood as a Blalock-Taussig shunt, which obviously has been done for 50 or more years, more than that now. This is a Sano shunt that comes from the right ventricle to the pulmonary artery. This was popularized mostly because certain centers who weren't getting very good results with the Blalock-Taussig shunt were able to get patients to survive with this so it's permeated. But we have found that there's a few things that are not optimal when we use the Sano shunt. So since 1985 is when Dr. Norwood first described this. We've had improving results. Again, a few of those were technical. Obviously, technically we found out how to do this better with circulatory arrest and to protect the heart and the brain. But mostly, I think it's been the multidisciplinary team approach of taking care of these patients before, intra, and then after the operation. Pulmonary blood flow is very significant. Again, the Sano shunt has been popularized because the patients do extremely well or better than the Blalock-Taussig shunt in the perioperative area. But the long-term implications of the Sano may be not as good because of pulmonary artery distortion. There's been a lot of publications that, and many centers have said that their results for stage 1 Norwoods have a better than 95% survival. Some of that has been obviously a increase in not only the centers that do this and do this well, but from a standpoint of taking the very high-risk patients and putting them into a hybrid situation. We're not doing a surgical one, which actually didn't count on your surgical mortality. That's being changed now, so we're actually coming kind of back into into reality, which we see in the STS database, where there's still about a 15 to 25% mortality in the best hands. This is a study. It's the only prospective randomized study ever done in congenital heart disease. It's called the SVR trial, or single ventricle trial. that looked at the Blalock-Taussig shunt versus the Sano shunt. I think there were 15 centers that had patients for this, and we looked at outcomes and adverse events according to shunt assignment. This is a very busy slide, but essentially, there's nothing that favored the shunt alone, the BT shunt. And there are two ones that were significant that favored the Sano shunt, is that a patient less than 2.5 kilos, and patients who have small ascending or transverse arches, the ascending arch being about less than 2 millimeters. So the conclusions of the single ventricle trial showed that there's lower original mortality with the Sano shunt. There is, however, higher reintervention and complications of the Sano. And as I said, that the Sano is connected to the ventricle and the pulmonary arteries, and as these children grow, what we've seen is that it pulls or tugs down the pulmonary arteries and can cause distortion. The other thing that we saw is that there's the subgroup increased risk. And what we see is patients weight less than 2.5 kilos, small ascending aortas, patients who have genetic syndromes, specifically patients that have mitral stenosis and aortic atresia because they can have coronary artery fistulas and the intact atrial septum. And here at UCLA, as Dr. Skolansky discussed, we are set up for these patients, especially with intact atrial septum and things of that sort, when patients are born and need immediate attention. This type of hospital situation we have and the multidisciplinary team we have helps us take care of this very, very difficult subset of patients. It's always kind of maybe be careful what you ask for. But our team has done an incredible job because it's not just the surgery and cardiology, but it's OB/GYN. It's the operating room staff because these patients are born in the operating room and go directly either to the operating room or the cath lab, and then stabilized and actually go back to the operating room or get a hybrid palliation. So this is the hybrid palliation. At UCLA, we do this on patients that we don't think are very good surgical candidates, and I'll discuss that a little bit in more detail. But in this cartoon, you can see essentially the duct is stented here, and Dr. Levy and Dr. Albehausen help us with that. And we do bilateral pulmonary artery bands. And so again, this creates that balance, and this allows us to either see if the patient can become a surgical candidate for a typical Norwood type palliation or transplant. So potential advantages of the hybrid, you think it'd be fantastic. You don't have to go on bypass. Allow these children to grow. How we say the hemodynamics and the outcomes neurologically are not as good as we would assume they would be for a few different reasons. The data is all retrospective and single centers with low numbers. There's not a lot of long-term follow-up. And really the biggest problem is that many centers, because they didn't get good surgical outcomes, will do the hybrid as their first palliation and kind of kick the can down the road. And so usually it's an extreme bias whether a center will just do hybrids or will do mainly surgical Norwoods and keep the hybrid for the more high-risk patients. So the data is strongest in 3 areas: the mortality, post-op hemodynamics, and fate of the pulmonary arteries. So mortality is actually higher in the same patient categories in the hybrid at the second operation. Post-op hemodynamics you'd assume would be better with the hybrid, but that's not true. We have done 2 this week actually, and you see that there's significant decrease in cardiac function over the first few days. The fate of the pulmonary arteries is actually extremely difficult in the hybrid because we have to band these, and they never really regain normal pulmonary artery status. And the neurodevelopmental is actually obviously difficult to assess. So overall, similar numbers. The mean hospital mortality in the SDS database for Norwood operation is about 17.3%. And the interstage between the first and second operation, which I'll discuss, is about 12.4%. The SVR trial showed that the patient's survival at about 1 year was 26 to 36%. Now, having said that, the best studies that looking at the hybrid procedure show that the second stage mortality for the hybrid is 25%, and they haven't discussed that the original mortality also for the original operation is close to 10%, and their interstage is similar. So Right now, the data favors a surgical Norwood for low and moderate risk patients. So the fate of the pulmonary arteries is, again, one of the most difficult things that we see with these hybrid patients because, again, they never return kind of to their normal anatomy. So the equipoise, really, there's no true data, and there are small numbers, and I was saying, like, usually centers either do one or the other, and right now the data supports the Norwood. Our algorithm is this. So low to medium risk, we do a surgical Norwood. These include low birth weight. We've done many patients less than 2.5 kilos, and small ascending aortas. It seems like, Mark, all we get are small ascending aortas. And we have overall mortality in this group less than 10%. Over the last couple of years, it's even less than that. In the high-risk patients, those with syndromes, those with extreme prematurity, as well as coronary artery fistulas, we will do the hybrid. And even with this, and like I said, our Dr. Skolansky and Dr. Satow have done such an excellent job getting the diagnosis of these patients, and given the way that our population is, for the high-risk group, it populates almost 50 to 60% of our patients. And so it's amazing that our team is able to do this on such an excellent level and get these outcomes. So the interstage period is the period between the first and second operation. Some people feel it starts the minute the patient leaves the operating room. I'm not quite sure. Those first 2 days are obviously very difficult, and again, takes a multidisciplinary team to take care of these patients. But the stage 2 palliation is in this cartoon. Again, SVC has been divided from the right atrium and sewn into the pulmonary artery, and whatever shunt was performed, either the Blay-Lactalstric shunt or the Sano shunt's been taken down. So the interstage period is between these two operations, and it's typically performed, the interstage mortality, what we see in the STS database, is about 10 to 15%. And so when these babies go home, a lot of times we know that it's not a huge surprise, and there's some kids that can be struggling because of ventricular function generally. But there are a few kids, especially during this time of year, that get a viral illness, and they get dehydrated very quickly and can have acute mortality. Interventions we have to reduce the risk is that each child is discharged with an infant scale and pulse oximeter, and they actually have a daily log, and if there's any derivation, they talk to our nurse practitioner who's on call every day for this data, which is a huge advantage to these patients, and obviously a huge job for this person. And the physician is contacted for desaturation, weight loss, or failure or plateau in weight. We have a very low threshold for readmission, catheterization, actually echo and catheterization. So the stage 2, again, I talked about is a bidirectional Glenn. When do we do it? We usually between 4 and 6 weeks, and generally the patients tell us when to do it because they've outgrown their shunt. Again, other sources of pulmonary blood flow. In this operation, they don't have other sources of pulmonary blood flow, especially, and so we generally have to employ this earlier. And hepatic factor, I'm going to skip. So stage 3, again, creating the monsters is the Fontan completion, usually around 3 years of age. We say 3 years of age, 13 kilos. Candidates and timings are very controversial. Obviously, the technical aspect is the extra cardiac Fontan is what we use here as a graph from here to here. And almost every center in America is doing this now. And we do not do a fenestration routinely, but we'll do it on a case-to-case basis. Ongoing issues have already actually been discussed, and the complications that happen with these patients. And again, we're actually just learning this because history is being written and we're writing it. I'd like to thank everybody else, and thanks, Jamil, so much for this opportunity.